Bismillah ar-Rahman ar-Rahim. At the beginning, I would like to thank Professor Hassan al-Maghrabi and Professor Fadi Muayati for their kind invitation, which I have accepted with pleasure. Also, I would like to thank Dr. Mayin Nahrawi for her excellent communication and organizational skills. My talk is about hysteroscopic morcellation, moving gynecological surgery to office. I declare no conflict of interest. Hologic has not contributed in any capacity to this work. Although well established in the United Kingdom, hysteroscopic morcellation is not performed in office on a large scale in many other countries. The concept of the patient ambulates in and ambulates out in modern hysteroscopic service is proven to be safe, efficient, convenient, and cost-effective by reducing theater utilization and bed occupancy. However, establishing such a service requires investment in ambulatory infrastructure, training, and referral pathways. In addition, it requires changing the culture and the mentality of practicing clinicians and increasing women's awareness. Endometrial polyps and submucous fibroids are found in up to 30% of pre- and post-menopausal women presenting with abnormal uterine bleeding. The conventional resectoscopy is highly effective for resection. However, it requires general anesthesia in theater, and tissue fragments have to be removed manually, adding to the operating times. In the last decade, the hysteroscopic morcellation technology was introduced as an alternative that can be performed in the office setting. It utilizes an irrigation and suction system for simultaneous resection and removal of tissues. This is the Omniscope that we use in our unit, and the MyoSure device comes in 3 sizes: light, reach, and XL, depends on the size of polyp or fibroid that you are removing. The technology is designed to be used in awake patients. You have to dilate to 5.5 millimeter Heger only in light and reach, and to 6 millimeter if you are using XL. The MyoSure device that I showed you is connected to the Aquilex fluid management system that allows accurate monitoring of fluid balance. Hysteroscopic morcellation has multiple merits. It is not associated with thermal injury. For the endometrium, this is beneficial to fertility and miscarriage patients. For the tissue retrieved, it allows reliable histopathological assessment. The treatment time is short, seconds to minutes. Also, it cuts and retrieves tissue at the same time, reducing the number of uterine manipulations, and that's what exactly you need for awake patients. In addition, the entire polyp, including the base, can be removed, reducing recurrence. This is different from blind twisting. Also, the fundal polyp or submucous fibroid, which is a challenge for the conventional resectoscopy due to difficulty accessing the base, is not an issue with the hysteroscopic morcellation. We conducted this study to evaluate the hysteroscopic morcellation service in a dedicated office setting in everyday practice outside the context of clinical trials. The primary objective was to assess the level of acceptability, factors affecting women's satisfaction. The secondary objectives were to assess complete resection rate, complication rate, and the pain score during the procedure and on leaving the unit. The study included 287 consecutive women undergoing hysteroscopic morcellation in office using MyoSure technology. The number of lesions removed was 554, with 7% of women had more than one pathology. It was a retrospective data collection using hospital electronic records. The study was performed in Sandwell and West Birmingham hospitals between 1st of January 2017 to 31st of March 2021. Most of cases have been performed by a team of 3 consultants with a special interest in hysteroscopy. A trained nurse hysteroscopist did some cases, while a few cases have been performed by 2 senior trainees under supervision. We carefully select our patients for office hysteroscopy service. The patient has to be motivated, not extremely nervous or prone to panic attacks, well-informed, consented for see and treat, has something to eat, and has no language barrier. I would say 80 to 90% of the population we serve fit this criteria. The analgesia was offered according to women's requirement and choice. Our local protocol includes paracetamol and ibuprofen taken 1 hour before the procedure, and we rely on our vocal local, which is the nurse assistant who holds the patient's hands and talks to her about holidays, schooling, and the children to distract her. Every woman gets these too. Some women require Intonox, 50-50 mixture of nitrous oxide and air, and some of them require local anesthetic. We don't provide opiate to prevent sickness and to help quick discharge. For local anesthesia, we give deep intracervical 4-quadrant block, and we use lidocaine hydrochloride with adrenaline. The needle should be passed to above the level of internal os. You have to insert the full length of the needle. The correct way is illustrated in the diagram on the left-hand side. This technique of intracervical block will block the inferior hypogastric plexus that innervates the lower 2/3 of the cavity. If the woman is paras with patulous cervix and you don't have to dilate, then local anesthetic will not be required. We also distributed an itemized satisfaction survey prospectively to all women undergoing the procedure in the last 15 months of the study period. It was completed immediately after the procedure. Visual analog scale was used as an objective assessment on a scale of 0 to 10. Visual analog score of 7 or more was used to mark satisfaction and also to classify anxiety and pain as severe. This is the validated survey that we used. I am the owner of the copyright, and I am happy to give it to anyone who would like to repeat the same exercise. As you can see, 87% of women in our cohort had polyps, 60% had fibroids, and 7% had both removed. 55% of women had intracervical block, 23% required gas and air, 15% had both, while 7% had nothing. About 75% of procedures were performed by a consultant. Our trained nurse hysteroscopist usually does easy, straightforward small polyps that don't have to be removed by a surgeon. Only 7 women required 2-stage procedure because of the large size, vascularity, or multiplicity of the lesions. No complications encountered in this series. All women left the unit within 30 minutes after the procedure, and the survey completion rate was 100%. Although 17% of women reported severe pain during the procedure, this was short-lived, and only 5.5% reported such pain on discharge within 30 minutes. Level of pain during the procedure had no negative impact on women's satisfaction, with 97% of women felt that they received adequate procedure explanation beforehand, and more than 95% of women found the procedure acceptable without general anesthesia, and they are likely to have the procedure repeated again in the future if required, and more than 95% would recommend the procedure to their family and friends. There was no significant correlation between the pain experienced during the procedure and the lesion size or the operator experience. The level of preoperative anxiety was positively correlated with the severity of pain during the procedure, i.e., the more anxious women felt pain. However, the level of preoperative anxiety didn't affect women's satisfaction with the procedure in office. The level of preoperative explanation and information giving showed positive correlation with the acceptability, willingness to undergo the procedure again, and the recommendation to family and friends. And it showed negative correlation with the pain experienced by women on discharge. Office hysteroscopic morcellation using simple analgesia is effective, convenient, and safe. It is associated with high women's acceptability and recommendation rates. The quality of preoperative explanation and information giving, both verbal and written, was crucial factors that increased women's satisfaction. Our results may encourage wider implementation of hysteroscopic morcellation in office setting across centers, with its multiple advantages both to women and service alike. Hospital episode statistics in England from April to July 2020 during COVID-19 pandemic showed 70% reduction in elective theater procedures, but only 31% reduction in office procedures. Therefore, to improve service efficiency, reduce backlog and waiting lists, we must move procedures out of theater, which was a valuable lesson learned from the pandemic. This is Sandoval Gynecology Suite, our dedicated office hysteroscopy unit. We have 2 procedure rooms and a recovery area. And our team that I am pleased to be part of. This is a video clip showing hysteroscopic morcellation of grade note submucous fibroid. I do apologize if the quality is not great, as it was recorded a few years ago. Our technology has improved since. I am using here my Assure Reach device. I injected 4-quadrant intracervical block, and the patient was using gas and air. This is one of the first cases that I have done. My dexterity has improved since, and I now use less and less of local anesthetic and gas and air. I do most of my cases now through the vaginoscopic approach without speculum or local anesthetic. I would like to thank every one of you for listening, and I wish you all the very best, personally and professionally.